Diabetes has become an epidemic. Diabetes is a complicated disease characterized by multiple metabolic and hormonal defects. A better understanding of the complex interplay between the islet hormones, insulin and glucagon, and the gut hormones known as incretins has provided new insights into the pathology of this disease. Research has shown that ingested glucose stimulates more insulin production than does an isoglycemic IV infusion of glucose. This is called the incretin effect. Around 60% of the insulin secreted is a result of incretin stimulation. When food is ingested, it stimulates intestinal cells to release incretin hormones into the blood. The primary glucoregulatory incretin hormones are GLP-1, or glucagon-like peptide 1, and GIP, or glucose-dependent insulinotropic polypeptide. These incretins act to modulate insulin and glucagon. The ratio of insulin to glucagon dynamically regulates blood glucose levels within a narrow range. In the fasting state, when glucose is not available from a meal, glucagon is secreted to stimulate production and release of glucose by the liver. Insulin levels are low. At mealtime, when glucose is available from a meal, insulin levels increase to facilitate the body's utilization and storage of the incoming glucose. Glucagon levels drop. Let's take a closer look. When food is ingested, glucose stimulates beta cells to secrete insulin. The incretins GLP-1 and GIP stimulate additional insulin secretion. At the same time, glucose and GLP-1 inhibit secretion of glucagon from alpha cells. It is important to note that incretin secretion is in proportion to the size of the meal, and the effect of incretins on insulin secretion is in proportion to the amount of glucose ingested. In healthy individuals, stimulation of insulin and suppression of glucagon result in inhibition of hepatic glucose production and facilitation of glucose homeostasis. The biologic action of GLP-1 and GIP in the bloodstream is short-lived. Following their secretion, these incretins are rapidly acted upon by the enzyme dipeptidyl peptidase 4, or DPP-4. DPP-4 cleaves two amino acids from the N-terminus of both GLP-1 and from GIP, resulting in incretin inactivation. The main abnormalities underlying type 2 diabetes include insulin resistance and islet dysfunction, involving both alpha and beta cells. In insulin-sensitive peripheral tissues, such as fat and skeletal muscle, insulin stimulates glucose uptake. In insulin resistance, there is decreased glucose utilization by these tissues. This is compensated for by increased insulin secretion and changes in beta cell mass. In patients with type 2 diabetes, alpha cell function is impaired as a result of the cell's inability to respond to glucose. The result? Glucagon secretion is excessive, and in the fed state, glucagon is not suppressed, causing inappropriate hepatic glucose output. Beta cells respond to hyperglycemia with increased insulin production. However, over time, in individuals with diabetes, beta cells are unable to compensate for the increased demand for insulin, resulting in hyperglycemia. Chronic exposure to elevated glucose and lipid levels contribute to beta cell damage, apoptosis, and loss of beta cell mass. In conclusion, the multi-system dysfunctions of type 2 diabetes make treatment extremely challenging.